that perspective.
Oh, yeah, so reading it more and more.
Your final lecture exam,
Perspective, baby.
your final lecture exam will cover the materials starting from urinary system 2. Okay, but since we didn't finish the urinary part 1, a few more slides we have to go. I will first finish that. But your final exam will start from lecture urinary system 2. Is it clear?
So we're not going to be on this material?
Not the last two slides that I will talk about. Okay. Okay. So in last lecture, you remember we have talked about the capillary structures in the kidneys. There are 3 capillary structures are present inside the kidney. One is the tuft of capillary or wall of capillary, that is the glomerulus, right? Yes. And then another one that is located around the short nephrons, cortical nephrons, and that capillary structure is called peritubular capillary. So this is short looped nephron, you see here cortical nephron, and around that, this capillary structure is peritubular capillary. And this is glomerulus, the tuft of capillary, and another one, ladder-shaped capillary structure around the long loop of juxtamedullary nephrons. And that capillary structure is called vasa recta. Okay, so those 3 capillary structures are present inside the kidney. Now, a very important structure that is called juxtaglomerular apparatus or JGA, and that structure consists of following things: enlarged smooth muscle cells of arteriole, and then the distal portion of the ascending limb of loop of Henle. I am going to draw here. This is the afferent arteriole. You know that afferent arteriole forms the glomerulus and then becomes efferent. Okay, so this is afferent and this is efferent. Now, here is the nephron. Like this and this. Okay. Now, when we see the picture in the book, most of the time you will see the nephron they have shown like this: proximal part, then loop of Henle, distal, and collecting tube, collecting duct, right? But actually, inside the kidney there are millions of nephrons, right? And kidneys are very small organs, and millions of nephrons are inside that, so they don't really get that space to spread like this. So all nephrons are heavily packed, okay? And so inside this picture we use just to make you clearly understandable. But actually inside the kidney everything is, squeezed like this. So how the nephron is located inside the kidney is, this is descending, this is ascending, and probably collecting duct is like this. Just know that everything is very squeezed.
I mean, they're not all in the
Not spread like
position that.
Right. So the afferent arteriole and this is the ascending limb of loop of Henle. These 2 structures are inside the kidney are very close to each other. Okay. So basically, the ascending limb comes very close to, located very close to the afferent arteriole. Make sense? Because everything is very close. Okay. So these 2 structures together form the juxtaglomerular apparatus. Okay. So which 2 structures? Afferent arteriole and last part of ascending limb of loop of Henle and the starting of distal convoluted tubule, actually this part, where the ascending limb ends and distal convoluted tubule starts. Okay, so
What's the name of what they form?
juxtaglomerular apparatus. Yeah. So those two structures from the juxtaglomerular apparatus. Now,
where the distal convoluted tubule is close to the afferent artery.
yes, ascending last part of ascending limb and the start part of the distal convoluted tubule. Make sense? These two parts. This is the afferent glomerulus, efferent, and this is the nephron. So what happens, the ascending limb comes very close to the arteriole, these two. So last part of ascending and the very early part of distal convoluted tubule. Okay. Now, what happens, the cells in the wall of afferent arteriole here, this is the afferent arteriole, and the cells of this part of the nephron are different than other parts. They are highly specialized cells. So in the wall of the afferent arteriole here, that forms the juxtaglomerular apparatus, has highly specialized cells. And those cells are called granular cells. Okay? So in the wall of afferent arteriole, that part forms the juxtaglomerular apparatus, has highly specialized cells. Those are called what? Granular cells. Okay, so granular cells are here. Now, the wall of the distal part of ascending limb of loop of Henle, these cells are also highly specialized. That part forms the juxtaglomerular apparatus. These cells are also highly specialized. And these cells are called macula densa. Macula densa cells. Okay? So, those two types of cells you will see in juxtaglomerular apparatus.
When the wall of the distal part of loop.
Wall of distal part of ascending limb of loop of Henle. Now, if you cut the juxtaglomerular apparatus here, if you cut here and make a cross section here and see under the microscope, you will see the structures like this. So here, this is the glomerulus, the tuft of capillary. Okay, glomerulus, and this is the distal part of ascending limb of loop of Henle. Make sense? So this is the part of the nephron, the tube, and this is the part of the afferent arteriole, glomerulus, efferent arteriole. Now, this part of afferent arteriole, you see these cells are granular cells, okay, granular cells, and these cells are highly specialized cells, different than the cells of other part of the wall of the afferent arteriole. So these are the granular cells, and these cells you see in the wall of the distal part of ascending limb of loop of Henle are also specialized, different than other cells. And these cells are called macula densa cells. Is it clear now?
Well, which ones are the granular cells? The first row or all the red row over here?
This is the afferent arteriole, okay?
Yeah.
This is afferent arteriole. This is glomerulus.
But which ones are the granular cells?
This is efferent. First, let me make sure. Did you understand? This is afferent.
Yeah.
This is glomerulus. They have actually dissected it. And this is what? Efferent. So I said that juxtaglomerular apparatus consists of afferent arteriole and last part of ascending limb or distal part of ascending limb of loop of Henle, right? So this is the ascending limb of loop of Henle and this is the afferent arteriole. Is it clear? Okay. Now, the wall of afferent arteriole has highly specialized cells in this part, not in other parts, okay? And these cells are called granular cells. Is it clear? granular
Well, they
cells.
look the same as all the rest of the part.
It doesn't matter. Okay? And these cells are also highly specialized in the wall of the ascending limb of loop of Henle. That part is forming just a glomerular apparatus. And these cells are called what? Macular denser cells. Now, the granular cells produce a chemical that is called renin. The renin is the chemical produced by granular cells. Okay? And renin plays a very important role in regulation of blood pressure. Just write it down that granular cells produce renin, and renin plays a significant role in the regulation of blood pressure. Okay? Now, the macular denser cells, what do? They can detect how much fluid is passing through or how much urine is passing through the tubule, because they are located in the wall of the ascending limb of the loop of Henle, right? So they are sitting there to detect the flow of fluid through the tubule, okay? So they are sensitive to the flow of the fluid, okay? So see, very nicely organized the things. These cells can detect the flow of fluid or urine inside the nephrons, and these cells do what? Regulates blood pressure. And how? By producing renin. Now, how these cells will know that I have to produce renin now? That is determined by the pressure of blood inside the afferent arteriole. So, if the pressure inside the afferent arteriole goes down, then the granular cells will produce renin. Because what's the function of renin? Increasing the blood pressure, right? So when renin should be produced? When the blood pressure goes down. And since the granular cells are sitting in the wall of the afferent arteriole, it can tell when the blood pressure goes down, right? So that's so nicely designed the things here in the juxtaglomerular. Okay. Now we'll talk about the different structure that is called the filtration membrane. So filtration membrane, by its name, you can tell it is the membrane through which the filtration takes place. It is the membrane through which the filtration occurs. It's like a filter, filter paper you use in chemistry. So it's like a filter paper membrane that allows the things to pass through. So the filtration membrane allows passage of water and solids smaller than most plasma proteins, but prevent filtration of large cells. So that filtration membrane will let very small things to pass through it, but will not allow the red blood cells to pass through it. And that is important. If blood cells pass through the filtration membrane, then blood cells will enter into the tubule, okay, and will get out from the body. So only the water and small molecules, smaller than most of the plasma proteins, those molecules will be able to pass through the filtration membrane. You understand the importance, right? If filtration membrane is actually nothing, this is the glomerulus, right? This is the glomerulus, and this is what? Bowman's capsule. Very good. You know that glomerulus is encapsulated by Bowman's capsule or glomerular capsule, right? So now this is the Bowman's or glomerular capsule, and this is the capillary wall, right? This is capillary structure. So this is the capillary wall. So those two structures together form the filtration membrane. And when the blood will pass through the glomerulus, the water and other small solids will be able to enter into the nephron. So if I ask you that filtration membrane here is formed by which two structures? One is the Bowman's capsule, and another is the wall of the capillary, right? This is the capillary structure, so wall of the capillary. So those two structures form the filtration membrane. So now let's see if this is the capillary, glomerular capillary, this is the wall, and here is the Bowman's capsule. So fluid, water and other solids has to pass through the filtration membrane. Now, if we see the structure of the capillary wall, glomerular capillary wall, it has two layers. If we see the structure of the capillary wall, it has two layers. What are two layers? Capillary endothelium and the basement membrane. Okay. So let me first see the structure of the capillary wall. Capillary wall has how many layers? Two layers. Very good. One is the basement membrane. This is the basement membrane. And capillary endothelium formed by squamous cells, simple squamous. So this is the wall of the capillary. Two layers, basement membrane and endothelium. Okay.
So what is this, the membrane?
Okay, so this is the wall of the capillary. Now, another structure is here. What is this? Bowman's capsule, right? So Bowman's capsule also has two layers. What are the layers of Bowman's capsule? Membrane of glomerular capsule and basement membrane. So this is the capillary, and now I am drawing the Bowman's capsule. So it has two layers also, basement membrane and the membrane of glomerular capsule. This is also squamous cells. Okay. Membrane of glomerular capsule. So now we know that the filtration membrane is formed by the capillary wall and Bowman's capsule. Capillary wall has how many layers? Two. And Bowman's capsule has how many layers? Two. Is it clear? Okay.
Do
Now,
they share the same basement?
yes. Now, since they are together, attached to each other, let's put them together. So let's put this part, basement membrane of Bowman's capsule, and the membrane here. So now you see 1, 2, 3, 4 layers, but these two are same thing, right? Both are basement membrane. So we can say one layer, fused basement membrane, because both the capillary wall and Bowman's capsule have basement membrane, right? Now if you can put them together, we can say this is one structure, because same thing, right? So 3 layers, capillary endothelium, membrane of glomerular capsule, and fused basement membrane. So those are the 3 layers.
Is it 2 layers of a basement membrane?
Yes. Okay, so this picture has shown the filtration membrane here. Okay, not a very nice picture. Just know that from this side is the blood, and here is inside the nephron. Okay, so the water and other small solutes pass through the filtration membrane. Okay, and there are many holes in the filtration membrane. Since it is a filter, so there are many small tiny holes through which the water molecules and other small solutes will be able to pass through. Mechanisms of urine formation. 3 processes, we have talked about that before. First is, see here, when the blood is circulating inside the glomerulus, this is glomerulus, right? While the blood is circulating inside the glomerulus, through the filtration membrane, you know that this is the filtration membrane, so through the filtration membrane, the water and other small solutes will enter into the first part of the nephron, and that is called glomerular filtration. Okay? So glomerular filtration is the process by which from the blood the water and other molecules will enter into the nephron. Then what happens? After the fluid enters into the nephron, fluid starts to run through the nephron, right? Through the nephron, and while the fluid is running through the nephron, two things happen in the wall of the nephron. One is reabsorption. What is reabsorption? Taken back into the body, right? Through the wall of the tubule. That is reabsorption. So reabsorption occurs, and another thing happens, that is secretion. What is secretion? Something is entering into the tubule through the wall from the body into the tubule. Okay, so that is secretion. So if this is the tubule of nephron, and here is the urine or fluid, so some molecules will get out from the tubule and enter into the body. That is called what? Reabsorption. Is it clear? Reabsorption. And some molecules will enter into the tubules through the wall of the tubules will enter, and that is the secretion. Okay. So all those three processes take place for the production, during the production of urine or formation of
Going out
urine.
is called reabsorption.
Second?
Whatever goes out of the tubule is called reabsorption.
Yes.
And
Out
whatever
means
goes in
Yeah.
is called
secretion.
secretion.
Out means going back into your body, okay? And getting in the tubule means going out from the body, because anything inside the tubule will eventually get out from the body as urine, okay? So those are the three processes for the formation of urine. Okay. Now we will talk about few other things in the second part of the urinary system. So in this part we will talk about filtration pressure and filtration rate. Then we will talk about a system that is called renin-angiotensin system. And then we'll talk about the tubular reabsorption and secretion countercurrent mechanism very briefly, and then we'll talk about the mechanisms of formation of dilute and concentrated urine. You know that sometimes our body produces concentrated urine, right? Sometimes diluted urine. How the urinary system produces the diluted and concentrated urine, we'll talk about that. Then we'll talk about the urinary bladder and urethra. Okay? And the hormones, two types of hormones work in the urinary system. One is the hormones, those are produced within the kidneys. And another thing, that hormones are produced outside of the kidneys and work on the kidneys. Two different things, right? Some hormones are produced inside the kidneys, and some are produced from somewhere else but work on the kidneys. Okay, so we'll see what are those two types of hormones. So you already know that three processes are needed for the formation of urine: glomerular filtration, tubular reabsorption, and tubular secretion. So what is filtration? Filtration is the process by which the water and other molecules from the blood enters into the nephron, right? That is the filtration. So there must be a pressure that is pushing the water and other molecules out from the capillary to the nephron. Makes sense? There must be a pressure that will push the things out. And that pressure is the filtration pressure. To push anything out, you need to use pressure. And that pressure that sends the water and other molecules outside from the capillary, that is the filtration pressure. Now, filtration pressure is determined by three factors. Three different forces work here. What are those three? One is called glomerular hydrostatic pressure. So, glomerular hydrostatic pressure is the pressure, see here, is the pressure that is trying to push the things out from the glomerulus, from the blood. So the glomerular hydrostatic pressure is trying to push the fluid out from the blood. Okay. Now, two other forces are working, and those are trying to oppose the glomerular hydrostatic pressure, working against the glomerular hydrostatic pressure. What are those two pressures? Opposing forces are colloid osmotic pressure and capsular hydrostatic pressure. So, how many pressure is favoring the filtration? One, right? And how many are opposing? Two. But the pressure that is favoring the glomerular filtration is more than the opposing pressures. If you put those two opposing pressures together, still it is less, right? So that's why the filtration is being taken place. Now, so if you see here, this is the glomerulus, so capillary and blood inside the capillary, and this is inside the Bowman's capsule, okay, inside the Bowman's capsule. Now, one pressure, that is the glomerular hydrostatic pressure, that pressure is trying to push the fluid out from the capillary. So that is indicated by the blue arrow here, okay, and then two opposing pressures. One is this green one and another is this cyan one. So now, what's the pressure of glomerular hydrostatic force? The glomerular hydrostatic pressure is 55 millimeter of mercury. That's the pressure trying to push the fluid out. Now, the opposing pressures, the colloid osmotic pressure is 30 millimeter of mercury and capsular hydrostatic pressure is 15 millimeter of mercury. Now, if you add these two opposing pressures, 30 and 15, that makes 45, right? 45 millimeter of mercury is trying to prevent the filtration, and 55 is trying to cause the filtration. So, if you subtract that, 10 millimeter of mercury is the pressure that is pushing the fluid out. Okay, so that's why the filtration is occurring. The fluid is getting out from the capillaries and entering into the nephron. Now, if I increase the colloid osmotic pressure to 40, then what will happen?
Both are going to be equal.
Both will be equal. Is it clear? And no filtration will occur because the pressure on both sides equal, right? So filtration will not occur. That means no urine will be produced. Filtration will produce the urine, right? No fluid will enter, urine will enter into the nephron. Okay?
Well, so in other words, if a person's blood pressure isn't regulated properly, then it'll affect your urine.
if the blood pressure is very low in heart failure, okay? If the blood pressure goes very low, then the pressure inside the capillary will be low, right? So in that case, the urine will not be produced, and that happens. If someone's blood pressure goes down, the urine production will go down, okay? And if it's really low, no urine will be produced. Okay. Now,
But you said that the renin is what will be produced,
yes.
and that will raise the blood pressure.
So it will try to protect all
Or
of
not
that.
the person's heart is.
When the pressure will go down, the urine will be produced, it will try to increase the pressure. Okay. Now, the glomerular filtration rate, or GFR, it is the amount of urine or filtration will occur in each minute in both kidneys together. Okay, so it is the amount of filtrate that will enter into the nephron in each minute by both kidneys. So millions of nephrons are working, right, at the same time. So all together, if you add all of them, how much filtration you are getting, filtrate you are getting in each minute, that's the glomerular filtration rate. And the glomerular filtration rate is governed by three things, three factors. What are those? Total surface area available for filtration, filtration membrane permeability, and net filtration pressure, or MFP. Now, let's see. So filtration membrane, you already know that filtration, this is filtration membrane, right? Filtration membrane is here. Now, if I draw the filtration membrane, just think that this is the filtration membrane, and how the total surface area of the filtration membrane could be bigger if, for example, your glomerulus, this is glomerulus, right? If your glomerulus is like this and my glomerulus is bigger, that means I have more, the length of capillary is more in my glomerulus, right? If you make it straight, the total length of glomerulus is more here. So that means if you cut the wall and make it flat, which one has more surface area total? This one. Very simple, right? So it can vary person to person. If someone's total surface area is bigger and another person's total surface area is smaller, where more filtration will occur? The bigger surface area, right? So this is one. The total surface area available for
So how
filtration.
does that translate into your regular, like, normal life? Like, would you have to go to the bathroom more, or like if you have bigger surface area?
No, this is just
filtering
the,
more?
within the physiological limit, there are variations, right? One person to another person, a lot of variations. So just think normal, don't think abnormal, okay? So normally, it could be different from person to, if my surface area is bigger than yours, then more filtration will occur. But remember, other factors like reabsorption, secretion, those are being taken place, right? So we can't tell exactly that if the surface area is more, then the urine production will be more. Because urine production is the final amount is getting out, right? But reabsorption and secretion is also being taken place, okay? So only we can say that the filtration, amount of filtration will be more, okay? So that is one, surface area. Number two, filtration membrane permeability. Just think that your and mine, the surface area is equal, but in your filtration membrane, you have more holes than mine. I have only few holes. Just think that way. Okay, so where more filtration will occur? Here, right? Although the surface area is same, but the quality of the filtration membrane is different, right? So that is another factor. In many clinical conditions, in infections, what can happen? Those holes can get closed. And since the quality of the membrane can get bad, so the amount of filtration will be less, although the surface area is equal. And another is the filtration pressure. Final pressure we get is 10 millimeter of mercury, that's normal. But as I showed you, that if any of those three pressures changes, then the net filtration pressure will be different. Make sense? So those are three factors.
So you're saying if there's an infection, so that would make it be that it would be an infection in the kidneys?
Yeah, chronic infection can
Close the hole.
close some holes.
So that would cause pain?
No pain, but production of urine will be less. Okay, and that will create complications. You know that if urine is not produced, the toxic things will not get out of the body, right? So that will cause other problems, not pain. And general infection causes pain, we know that.
Sick.
If you get infection, the pain will occur in that.
Well, how would a person know to go to the doctor?
If you have, like, first one is pain is of course important. Like if you have kidney infection, then you will feel pain, right? Then you have to go to the
I have a question, it's not
Yes.
really related to the subject, but why do people that have diabetes pee a lot?
Okay. In diabetes, there are two types of diabetes. In common type, that's the diabetes mellitus, right? So in diabetes mellitus, the sugar amount in the blood is more, right? So the osmotic pressure increases. That increases the hydrostatic, glomerular hydrostatic pressure. So
So more stuff is getting into the kidney?
yes.
More fluid,
That
okay.
makes sense. Okay, so now we'll see what happens while the fluid, after the filtration, fluid enters here, right? Then, while the fluid or urine is passing through the nephron, what happens? First we'll see what happens in the proximal convoluted tubule, the first one. In the proximal convoluted tubule, 65% of volume of urine will be, or fluid will be reabsorbed. So, like if your kidney produces 100 milliliter, then how much will be taken back into the body? In the proximal convoluted tubule, 65%. That means 65 milliliter. If your kidneys produce 100 milliliter, 65 milliliter will be reabsorbed. Where? In the proximal, in the first part. So you see that more than half of filtrate will be taken back into the body in the proximal convoluted tubule. And which chemicals will be taken back? Just know that, write it down. In the proximal convoluted tubule, it is not selective, it will take everything back in equal, almost equal amount. So, everything will be taken back into the body through the wall of the proximal convoluted tubule, or in the proximal convoluted tubule. Everything will be reabsorbed, and 65% of volume. Then,
Why does it say 65% of sodium and water?
those are the main two components, but just write it down, everything, okay? Then, the fluid will enter into the loop of Henle, next part of the nephron. And loop of Henle has how many leaves? Two. The descending and ascending. Very good. So, this is the loop of Henle. This is descending. This is ascending. The descending loop of Henle is very selective. selectively permeable, only water molecules, it will let only water molecules to get back into the body. Which limb? The descending limb. Okay? So descending is only permeable to water and will let the water get back into the water. Reabsorption of water will take place in the descending. Now, the fluid will enter into the ascending limb. And while the fluid will pass through the ascending limb of loop of Henle, it is also very selective, but will let the sodium chloride and a small amount of potassium to get reabsorbed.
And what's the CL is the chloride?
Yeah. So sodium chloride, salt, very good. Sodium chloride, salt, and some potassium will be reabsorbed. No water. So see that two limbs are different. The descending limb is letting the water only to get back reabsorbed, and ascending limb is only allowing the sodium chloride and potassium to get back into the water. Okay? Now you tell me, if I ask you, while the urine or fluid is going down through the descending limb of loop of Henle, inside the descending limb, the concentration of fluid will increase or decrease?
Decreases because water is being
The
absorbed.
concentration will
Increase.
increase. The reason is you are taking out the water, okay?
Oh.
So gradually the concentration of urine will increase. Now you tell me, while the urine will pass through the ascending limb of loop of Henle, the concentration will increase or decrease? Because you are taking the solutes out, sodium chloride out. Water is there. Okay? So the concentration will decrease. So remember, that is very important, okay?
So does it end up being the same as it was before? By the
Yes.
time it gets through? Like, I mean, first it takes out the water, then it takes out
Yes.
these ions.
Yes.
Well, it doesn't take the other stuff, but.
Okay? So the difference is the chemicals, but the concentration will again come back. Okay. So now next part is the distal convoluted tubule and collecting duct. The last two parts, distal convoluted tubule and the collecting duct. So in these two structures, the reabsorption is regulated by hormones. So in these two structures, the hormones will work to control the reabsorption. So which hormones? Just remember, three hormones will work in these two parts of the nephron. One is parathyroid hormone, or PTH, that helps in reabsorption of calcium, and then ADH, or anti-diuretic hormone. Anti-diuretic hormone comes from the pituitary, posterior pituitary gland. ADH is what? Anti-diuretic hormone comes from where? Pituitary, the posterior pituitary gland. And then what the ADH will do? ADH will reabsorb water. Okay? And another one is aldosterone. Aldosterone is produced in the adrenal gland. Adrenal gland is located where? On the kidneys, on the top of the kidney. So aldosterone comes from the adrenal gland and helps in the reabsorption of sodium. Okay? So let's see what happens there. So urinary system is really very interesting. If you understand, it will be very easy for you to understand the clinical conditions related to the
Where did you say that the ADH was produced?
ADH is produced in the posterior pituitary. Okay, so this is the distal convoluted tubule here, distal convoluted tubule, and this part is what? Collecting duct, right? Collecting duct. Now, these two parts are controlled by what? Hormones. Okay? And three hormones. Parathyroid hormone or PTH comes from where? Parathyroid glands. Parathyroid hormone comes from parathyroid glands. Okay, now PTH does what? Reabsorbs the calcium. So if the calcium concentration in our body goes down, then parathyroid hormone will do what? Will produce or release more PTH, right? And that will go to the kidney tubule and will do what? Reabsorb the calcium.
But it'll be in together with the fluid that's going out of the body? Or will it be on the other side of the tubule?
Other side in the body,
It'll be outside of the tubule
but
to
inside the
cause
body.
it, to come out.
Take the calcium back, right? So see here, very simple, right? Very simple. If your body or blood level of calcium goes down, then your parathyroid glands will do what? Release parathyroid hormone, and that will work on the kidneys, kidney tubules, will help in reabsorption of calcium, and we know that reabsorption is taken back, right? And the calcium level will stay high. That is one. Number two, antidiuretic hormone comes from where? Pituitary, posterior pituitary, and will work on kidney tubules. So see that produced in the brain, right? The pituitary gland, and working so far, and very specifically working on the kidney. Not only very specifically working on the kidneys, which part of the kidney tubules? The last part. So it is so selective, right? It's not working in the first part, but only working in the last part. So what the antidiuretic hormone will do? It will reabsorb water. Reabsorb water. Now you tell me, if more antidiuretic hormone is released, then reabsorption of water will be more. The volume of urine will be more or less? Less. Okay. So antidiuretic, by its name you can tell. Diuresis. What is diuresis? Excessive production of urine. Diuresis is production. Have you heard that term, diuresis? No? Okay. So we commonly use that term. Have you heard diuretics?
Yes.
Diuretics will do what? Diuresis. Okay. So what are the diuretics?
Heavy.
Yeah. What's the function of diuretics? Urine production. So diuretics will cause diuresis. So diuresis is what? Production of urine. Okay. So antidiuretic hormone will do what? Will not produce, stop production of urine. That means will produce less urine. Okay. So why we use diuretics? If someone has high blood pressure, if someone has high blood pressure, if you take that person to the hospital, first thing they will do, they will give diuretics, Lasix or something, that will produce more urine. If urine is produced more, that means the volume of blood or body fluid will go down, right? So blood pressure will go down. Make sense? So very important hormone, right? We use to block it or release it. Yes.
So the leukopen, the water in the descending is what gets reabsorbed, but that's not caused by hormone?
Not hormone. That part is not sensitive to hormone. Okay? Only the last part, last two parts. Okay. So now, if someone has pituitary tumor, that will do what? Destroy the pituitary cells, gland, and ADH will not be produced, right? Less ADH will be produced. So water will not be taken back into the body. Make sense? So more urine will be produced. And that clinical condition is called diabetes. Have you heard that?
Yeah.
Diabetes insipidus. So due to the distraction of pituitary gland or due to the lack of production of antidiabetic hormone, ADH will not be released, so it will not be able to take the water back into the body, it will stay inside the nephron and will get out from the body. Right? Make sense? So that is diabetes insipidus, not related to insulin or sugar. That's related to the pituitary gland and ADH or antidiabetic hormone. Okay?
So what do they do for that condition?
Okay, now aldosterone. Aldosterone does what? Reabsorbs sodium. If I ask you, aldosterone is produced where? In the adrenal gland. Remember that, I may ask this question. Aldosterone is produced by the adrenal glands and works on the kidney tubules and does what? Reabsorbs the sodium. Very good. Sodium. Now, remember one thing.
What does ANP stand for? What does ANP?
Just talking to.
It's just another word.
Yeah, another one. Not very important. Okay, so aldosterone reabsorbs sodium. Now remember one thing. When sodium has a tendency to hold water molecules with it. Okay, have you seen that sodium chloride? If you put the salt outside, it will take the water from the air, right? The sodium always tries to bind with water molecules. Okay, so when sodium will be reabsorbed, taken back into the body, sodium will take water molecules with it. Make sense? So water will also be taken back into the body. And so now if I ask you that more aldosterone means more sodium is going back, right? Also more water is going back. So aldosterone will increase or decrease the blood pressure. If more water goes back into the body, the volume of blood will be high. So the blood pressure will go up. Okay? So aldosterone increases the blood pressure that way. Okay? That's why you will see that if you have hypertension or high blood pressure, go to the doctor. Doctor will say, don't take too much salt. Because sodium holds the water, will not let the water to get out from the body. Okay? And will keep the blood volume high, increase the blood pressure. Okay? So just remember those three hormones, from where they are coming into the kidneys and how they work.
Okay, so if a person doesn't have a problem with blood pressure, so and if they have a lot of salt, then their body is able to moderate their blood pressure anyway?
Yeah, if the systems, all systems are working fine, then our systems have some maintain the homeostasis, right? If something goes up, all systems work together to bring it down.
So it will secrete the salt like extra when your body's working
More
fine.
salt will get out from
So it's just that when a person has high blood pressure, their body isn't getting rid of the salt that they're taking. So they have to increase
No,
their salt.
it's getting out eventually, it's staying longer time, right? Staying in the
It's not
blood.
working as good
Right,
as it
it
should.
doesn't get out immediately. Whatever you eat, it stays for a while, right? So the pressure will get out. Okay. So now we'll see the secretion, what chemicals are secreted inside the tubule. Just remember the names. Urea, uric acid, excessive potassium. If the potassium level goes up in our body, that will be secreted through the wall, and hydrogen ion. So remember those four: urea, uric acid, excessive potassium and excessive hydrogen. Now, urea, uric acid, you know that those are toxic chemicals produced during metabolism, and they must get out from the body, and some of them will be filtrated here, but some of them will directly enter into the kidney tubules through the wall, and that is the secretion. Okay? Some potassium and hydrogen. Now, hydrogen ion is very important, the secretion of hydrogen ion. Why? Hydrogen ion secretion controls the pH. You know that. If your body becomes acidic, acidosis occurs in your body, that means hydrogen ion concentration is more, right? Okay. So, in that case, what will happen? More hydrogen ion will be secreted. So, hydrogen will enter into the urine and will get out of the body. Very simple, right? If hydrogen concentration increases, your body will become acidic, and in that case, your kidney will come forward and will let the hydrogen ion to enter into the kidney tubules and it will get out. So, secretion of hydrogen ion is important. Okay. Now, we'll talk about the renin-angiotensin mechanism. Okay, so renin is produced by which cells? Granular cells in the wall of the afferent arterioles. Remember, the wall of the afferent arteriole are highly specialized cells, those are called granular cells, and they produce renin. When renin will be produced? When the blood pressure will go up or down. What's the function of renin? I said increase the blood pressure, right?
Yeah.
So when the blood pressure will go down, the renin will be released from the granular cells. And renin is doing what? Renin will convert a chemical that is called angiotensinogen, and will convert the angiotensinogen to angiotensin 1. Okay? So that is the function of renin. And then angiotensin 1 will go to the liver. From the kidneys, the angiotensin 1 will go to the liver, and inside the liver we have an enzyme that is called angiotensin converting enzyme, ACE, and that angiotensin converting enzyme will convert the angiotensin 1 to angiotensin 2, and remember that angiotensin 2 is the active form, so angiotensinogen must be converted to angiotensin 2, otherwise it won't work. So first,
You said the angiotensin 1 goes to the liver and is
yes, and there is an enzyme that will convert the angiotensin 1 to angiotensin 2. Okay? And then angiotensin 2 is the active form, and it will work. It will work on a number of organs. But remember that main action of angiotensin 2 is increasing the blood pressure. That's why I said that renin will increase the blood pressure. More renin means more angiotensin 2, right? So more angiotensin 2 means it will control the blood pressure more. Now, what will trigger the granular cells to release renin? I have already mentioned, right? If the blood pressure goes down in the afferent arteriole, then the renin will be released. When the blood pressure, the mean arterial pressure will go below 80 millimeter of mercury, mean arterial pressure. Now, if I ask you what is mean arterial pressure, do you remember?
No.
Do you remember pulse pressure?
No.
What is the pulse pressure? Difference between systolic and diastolic. That's the pulse pressure, right? and mean arterial pressure is diastolic plus 1/3 of pulse pressure. Right? Now everybody remember. Okay, so if the mean arterial pressure goes below 80 millimeter of mercury, then the granular cells will release the renin. Okay? Just know that. And I said that angiotensin 2 is the active form and it will work on a number of structures to regulate the blood pressure. Angiotensin 2 will contract the smooth muscle fibers, and we know that the wall of blood vessels has smooth muscle. So when the smooth muscle contraction will occur in the wall of the blood vessels, what will happen? The blood pressure will increase. The blood vessels will constrict, right? Get narrower, so the blood pressure will increase. Direct action. Directly it will work on the smooth muscle of the wall of the blood vessels and will cause the vasoconstriction, constriction of the blood vessels. Okay? That will increase the blood pressure. It stimulates the reabsorption of sodium. Okay. So here, come back, see here. If the sodium is reabsorbed, then more water will go back into the body, right? Because sodium tries to hold the water. So blood volume will increase. That will increase the blood pressure. So angiotensin 2 can directly work on the nephron and help in the reabsorption of sodium to increase the blood volume, that will increase the blood pressure. It also stimulates the adrenal gland to release the aldosterone. That will do the same thing. You know that aldosterone will reabsorb the sodium, right? So, two ways it will help in the reabsorption of sodium. One is it will directly work on the renal tubule, kidney tubule, and help in reabsorption of sodium. Another is it will stimulate the adrenal gland to produce aldosterone. That will do the same thing. Okay, and then angiotensin 2 stimulates the hypothalamus to release the antidiuretic hormone and activates the thyrosine. Now, don't get confused. Who produces antidiuretic hormone? Posterior pituitary. Hypothalamus is sitting above the posterior pituitary and regulates the posterior pituitary gland. Okay? So, the angiotensin 2 will stimulate the hypothalamus. So hypothalamus will send more signal to the pituitary, right? And pituitary will release more antidiuretic hormone. Okay? So that is one. And also angiotensin 2 will, so if more ADH is released from the posterior pituitary, it will reabsorb more water, right? So water will go back into the body, less urine will be produced, right? So the blood volume will go up. That will increase the blood pressure. So see, everything is increasing the blood pressure, right? And
so what you're saying is that it is the posterior pituitary because the hypothalamus gets it kick?
yes, yes, exactly. To
Give the
send signal to
extra
the posterior pituitary to release more. Yeah. To stimulate the posterior pituitary. And another is it will stimulate the thirst center in the hypothalamus. You remember in NP1, I mentioned that hypothalamus controls the food and water intake. Do you remember? How much food and water you take, that is controlled by your hypothalamus. So the angiotensin 2 will stimulate the hypothalamus thirst center. There is a thirst center in the hypothalamus. And so if the thirst center is stimulated, then you will feel what? Thirsty. You will drink more water. So the blood volume will increase. That will increase the blood pressure. So see that it's working on so many structures, but all works are to increase the blood pressure, control the blood pressure.
First or third?
Thirst. Okay. So I am repeating again. You help me. So if the blood pressure goes down, then the pressure inside the afferent arteriole will also go down, right? and in the wall of the afferent arteriole, in the juxtaglomerular apparatus, you have granular cells. That cells produce what? Renin. Is it clear? Renin. When the cells will release renin, when the mean arterial pressure will go below 80 milliliter of mercury. Make sense? So that will trigger the release of renin. And renin will do what? Will convert the angiotensinogen, that chemical, to what? Angiotensin 1. Okay? But angiotensin 1 is still not active. So it will go to the liver, where ACE, angiotensin activating enzyme, will do what? Convert the angiotensin 1 to 2, which is the active. Okay? Now, angiotensin 2 works on a number of structures. But to do what? Increase the blood pressure. So it will work on the blood vessels directly. Which part of the blood vessels? The smooth muscle in the wall of the blood vessel, and will cause the vasoconstriction. That will increase that will have direct action, right? Number 2, it will directly work on the kidney tubules and help in the reabsorption of, will cause the reabsorption of sodium. That will take water back into the body, blood volume will increase, right? Blood pressure will increase. It will stimulate the adrenal glands to release aldosterone. Aldosterone will also work on the kidney tubules to do what? Reabsorption of sodium. So the water will go back and blood pressure will increase. It will stimulate the hypothalamus to do 2 things. 1, to tell the hypothalamus to send signal to the posterior pituitary. It will release the antidiuretic hormone or ADH. That will work on the kidney tubules and reabsorb water. Make sense? Antidiuretic hormone will produce less urine and more blood volume. And it will stimulate the first center in the hypothalamus that will make you thirsty. So you drink more water. Okay? So many interesting things that angiotensin 2 is doing, right? Okay, regulation of concentration of urine and volume. Those two are very much related to each other. The concentration of urine and the volume of urine, right? If the concentration is high, that means the volume of urine is less. Okay? So how those are controlled? There is a mechanism that is called counter current mechanism that helps in the production of regulation of concentration and volume of urine. We'll talk about that briefly. Just know that if you see inside the kidney, and test the concentration, measure the concentration of urine inside the kidney, if you take a drop of urine from the cortical part, very outer part of the cortex, the concentration is very low, 300 milliosmol. 300 milliosmol is the unit, MOSF, milliosmol, okay? That's the unit of concentration. So in the outer part is very low. As you go inwards towards medulla, deep medulla, the concentration gradually increases. Okay? So you see here in this picture, as you go inwards, the concentration increases gradually, and at the very deeper part of the medulla, the concentration is very high, which is usually 1200 milliosmol. Okay? So several times more. Okay?
That's why the juxtamedullary
Very good, yes.
things have more concentration.
More concentrated, because juxtamedullary is going all the way deep, right? Not the cortical. Now, if you just see that this is the long looped nephron. Which part of nephron is in the cortex and which part in the medulla? Okay, so if you draw a line here, that will roughly tell you that this is the cortex here, cortex, and this is the medulla. Okay, so now these structures in the cortical part and these structures in the medulla. So now, if you take a drop of fluid or urine from here and take a drop of urine or fluid from here, where it will be more concentrated? Yeah, the deep medulla, right? Because this is medulla and this is the really deepest part of the medulla. So here we can expect how much? 1200. And here 300 milliosmoles. Okay. Okay. And do you remember that when the fluid is going down through the descending limb of loop of Henle, what is being reabsorbed? Water. Very good. That makes sense now, that when the fluid is going down, the concentration is increasing, and at this point it will be the highest, right? And then when the fluid is going upwards, the sodium chloride and potassium, right? Sodium chloride, potassium will be reabsorbed. So the concentration again will go, no, here is the high, right? Go down, because you are taking the solutes out. So, not the water, so the concentration is decreased. Okay, so that's why this part has low concentration, this part has high concentration. Okay, and then these two parts are heavily controlled by what? Hormones. Okay, so basically, if the urine will be concentrated or diluted, that is regulated by the last two parts, because here everything is happening same to everybody because it is not controlled by hormone, right? So 65% will be reabsorbed here, then water will be reabsorbed here, sodium chloride, potassium will be reabsorbed here. That's normal. Nobody is controlling it. It will happen in normal amount. Now, here we can manipulate, right? Because hormone is working. If hormone is there, it will be different than if hormone is not there, right? If ADH is more here, just think that antidiuretic hormone, ADH, is more here, then what will happen? Reabsorption of water will be more, right? So the volume will be less. The urine will be concentrated, highly concentrated. More ADH means more concentrated. So you see that basically the diluted or concentrated urine, that will be determined by the last part of the nephron, the hormones who are being there. Okay. Now I'll just briefly tell you about the counter current mechanism, not in detail, just very superficial. It's very interesting. So this part is what? This part is the loop of Henle, right? Loop of Henle. And the artery around the loop of Henle, the capillary structure, that is called what?
Vasa recta.
Vasa recta. Very good. So this is vasa recta. This is the loop of Henle. Okay. Now you see what happens. Through the loop of Henle, the fluid goes this way, right? This way. And through the ascending limb, the fluid will go up. Through the descending limb, the fluid will go down. Okay? In vasa recta, inside the vasa recta, that capillary, the fluid is going this direction. Okay? So now, if we see first these two limbs of loop of Henle, the fluid is going in opposite or same direction? Opposite. Counter current. The flow is in opposite direction. That is one thing. Now, if you see the limb of loop of Henle and the capillary, inside the capillary, vasa recta, the fluid is going in opposite direction. Okay, so that's why it is called the counter current mechanism. That thinks fluid is running in opposite direction, in between two limbs of loop of Henle, as well as in between the loop of Henle and the limb of vasa recta. Now, in this part, you know that water gets out from the descending limb of loop of Henle, right? Water gets out, and that water will first enter into the interstitial space here in our body, the kidney, and then will enter into the vasa recta. So water will get here, water. Okay?
It goes out into the interstitial space.
Yeah, interstitial space means the cells in the tissue. Okay, and here sodium chloride, right? And potassium gets out. And those will eventually enter into the capillary here. Okay. Now, if you see here, now if I ask you that while the fluid is going down through the descending limb of loop of Henle, the concentration is increasing or decreasing? Because water is getting out, right? Now, the concentration of blood is increasing or decreasing? Increasing, right? Because the concentration is decreasing because water is getting in. Is it clear? I'm repeating again. I'm repeating again. Okay, so this is the descending limb, right?
Right.
And what happens? The water gets out. So if I ask you, the concentration of urine is going up or down? Going up. Very good, right? Inside the descending limb. Now that water is eventually entering into the vasa recta here. So if water enters into the blood, the concentration of blood will go up or down?
No,
Down.
down.
Right. So while the fluid, blood is running through the this one, the capillary, the volume, the concentration is going down, but here the concentration is going up. Opposite direction here too, right? So see here, everything is opposite.
Well, the
Everything
volume
is
is
opposite.
going up with the blood,
Yes, the
but the
volume
concentration is going down.
down. So everything is opposite, okay? So that's why it is called countercurrent multiplier, countercurrent exchange. Just know that this is the basic thing what's happening, okay? Inside
So
that.
why is it called the vasa recta? Is that only if it's the blood in the Henle, it's called vasa recta?
So then recta indicates straight.
But that's only for the one that's the depressed biliary. So if we're talking about the other one, then what's that called?
Cortical, right? Cortical from short method. So countercurrent mechanism works on the long loop method.
Oh, so this system only works on the long loop?
Because vasa recta is only in the long loop. The urinary bladder. What's the function of the urinary bladder? Storage of urine, okay?
Oh, the bladder. Oh, I thought you said
No, the function of the bladder is storage of urine. Okay, for few to several hours. Your kidneys are continuously producing urine, right? If you didn't have urinary bladder, what could have happened?
Leak out all the time.
Yes, leak out. Okay. That's disgusting, right? Certainly, it is. So we need something to hold the urine. Because kidney blood is circulating, filtration is being taken place 24 hours. So we need something to hold the urine for several hours. So that's the urinary bladder. That's the function of the bladder. Okay? So if you see the wall of the urinary bladder, there are three layers. The innermost layer is the lining epithelium formed by transitional epithelium. And so remember that transitional epithelium is the inner lining of the urinary bladder. Why transitional? Because remember, transitional has two very important properties. One is said what? Stretching. So we know that urinary bladder, when empty, is very small. When it expands, gets right. So those cells can take a lot of pressure. Number one. Number two, the transitional epithelium doesn't allow any anything to get reabsorbed. Okay? No absorption occurs through the transitional epithelial lining. So once the urine is in your urinary bladder, you don't want the urine to go back into your body, absorbed into the body, right? You don't want that. So transitional prevents the absorption.
So it's kind of like a plasticky kind of a,
Yeah, so it will not let the urine go back into the body.
open it absorbs.
Is it clear?
No, it stretches though. It absorbs when it absorbs and stretches.
No, it doesn't absorb. No,
It doesn't absorb, you said, but yet it stretches.
It's distorting.
Okay, so two properties that transitional has. One is what? Stretching. Another is
Doesn't allow room.
doesn't allow the urine to go back into the body. Doesn't allow the absorption. That is very important. Otherwise, what's the purpose of production of urine if it goes back from the bladder to your body? Right? So those two. Okay. Now the middle layer is the thick muscular layer. That is a special type of smooth muscle. That muscle is called detractor muscle. Okay, and these muscle fibers have more elasticity. They can expand more. Then the outermost is the fibrous adventitia, and in the upper surface of the bladder we have the peritoneum, because in the abdominal, if this is the abdominal cavity, we know that the urinary bladder is in the lower part here, and peritoneum goes like this and only covers the upper surface of the bladder here like this. So upper surface has the peritoneum. Okay, so those are the three layers of the urinary bladder. Now if you cut the urinary bladder and see inside, you will see two areas clearly. The most part, if you see inside the bladder, has rough surface, lot of folds, like the stomach. Inside the stomach, you remember there are many folds. Those are called rugae. Similarly, inside the urinary bladder, most part has rough surface and rugae are present, folds. But one part, a triangular area, is there, and that area is very shiny. If you cut the bladder and see, you can tell by looking naked eye without microscope. It's a very shiny area, triangular. That area is called trigger. So that area is smooth and shiny and located between three openings in the bladder. Which three openings? We know that two ureters bring the urine into the bladder, right? So the openings of those two ureters and the urethra, right? Urethra is another opening for urethra. And if you connect those three openings by imaginary lines, urethra.
Wait, two for the ureters?
Two for the ureters and one for the urethra. Now if you connect those three, the area, triangular area, right? 3 points, so triangular area, that area is the trigon, okay? And trigon is like a funnel. You are just looking one half, so like this, you see here, you are looking one half, so you are looking like this, and there is another half like this, right? So if you put them together, it is like a funnel, and that helps the urine to get into the urethra. The function of funnel, we use the funnel, right, to put the fluid in narrower area. So that's the function of that funnel. Then trigon is the location where most of the cases the infection occurs. Urinary bladder infection, in most of the cases what happens in the trigon. Now the urinary bladder can expand a lot, and when the urinary bladder is very expanded, then the rugae disappears, becomes invisible. When it is empty, then the rugae becomes more prominent. Okay. Now, the urethra. This part is different, only this part is different between male and female. So male urethra is much longer than female urethra. Female urethra is 3 to 4 centimeter in length or long, and male urethra is 15 to 20 centimeter. So male urethra is 15 to 20 centimeter, and in the urethra there are two sphincters. The internal urethral sphincter and external urethral sphincter. So it's like the sphincters in the anal canal. In the urethra, you have two sphincters. So one is like here, and another external is here. So now, which one we can control? Okay, external. And external is formed by skeletal muscle, because we know that skeletal muscle is voluntary, and internal is smooth muscle, we cannot control. So very similar to defecation, in micturition, when you decide to urinate, first we relax the external, because we can do that, right? We relax the external urethral sphincter voluntarily. Then from that sphincter, the signal will go to the spinal cord. And from the spinal cord, a nerve signal will come to the internal sphincter and will open the internal sphincter. So external is already open. Now the spinal cord is opening the internal one, right? So the urine from the bladder will get out easily. Okay? So that's the mechanism. Now you know that sometimes the old people or very small infants, right? They cannot hold the pee. Why? In case of infants, it takes a couple of years to develop the motor control, the motor center. And we control our skeletal muscles by what? The motor center, right? Motor control. So they cannot control the sphincters. They have no control on their sphincters, right? So they can't hold. Old age, also same thing happens. Our motor control gradually gets weaker on the muscles, right? The muscle tone.
It's because of the brain
weaker.
messages,
Yeah,
or
right,
is
yeah.
it because of the giving birth and,
Old people, the muscle tone gets less, weaker. Muscles get weaker. Why? Because the motor center cannot control the tone very effectively. Okay, so the sphincters are loose, so they cannot hold.
And how do some people potty train their little kids, like when they're really, really young?
Like 9 months old.
Yeah, like
Yes.
people.
So when you
I mean, I know, I
They say
know.
it's just a habit that they.
no, not you can train your brain. You can train. That's the plasticity. You train the brain to do the task. You know, training makes the things faster.
So it's not really the sphincter, it's the,
Everything is motor control.
Did you want us to know the lining of the urethra?
Yes. So urethra is interesting because urethra has 3 different epithelial linings. Urethra has 3 different epithelial linings, and very important for both your lab and lecture. So first part of urethra is lined by transitional epithelium. And second part of the urinary bladder is lined with, it's not here,
it's there.
Go back. Keep going. There.
okay. Second part is lined with the pseudostratified columnar, and last part is lined by stratified squamous. Now see, It's not difficult, it makes sense. What is the lining of the urinary bladder? Transitional, right? Transitional, that I have talked for a long time. Transitional. So the urinary bladder has transitional. So the first part of urethra has what? Transitional. Makes sense? Because first part is connected to the bladder, right? So from the bladder, little bit, the transitional goes inside the urethra. So only very small first part is lined by the transitional. Makes sense? Comes from the bladder. Comes from the bladder. And then second part is the most part, is lined by the pseudostratified column. And pseudostratified has what? Cilia. Here, cilia, right? And that is important because you know that a number of important things, that cilia will move like this and let the urine get out completely. Okay? So no urine will stay there, will get out. Through the urethra, in male urethra, you know that the sperm, right? Semen gets out. So the cilia helps their movement. Okay? So a number of functions are done. Then the last part is lined with stratified stroma. Last part is close to the outside of the body, right? No. So the last part is exposed more to the outside, right? And chance of friction is more in the last part because that is the part which is the outermost. So where a lot of friction can occur, that part is lined with what? Stratified stroma. So we have talked about that a lot, okay? So that's why when you will just think, it makes very easy, right? That's why those three parts are lined by three types of epithelium, okay? Okay, now the male urethra has three portions. What are those three parts? Prostatic urethra is the first part. That part is inside the prostate. That's why it is called prostatic urethra. Then membranous urethra passes through the urogenital diaphragm. There is a diaphragm called urogenital diaphragm. That diaphragm, inside the diaphragm, that's the second part. That's the shortest part, membranous urethra. And last part is the longest part. That's the spongy urethra, also called penile urethra. Spongy or penile urethra inside the penis. So those are the three parts of urethra. First part is inside the prostate. Second part is urogenital, inside the urogenital diaphragm. And third part is inside the penis. Okay, so those are the.
So for a male, the sperm is the same, it goes through the urethra and goes to the urine.
This is the prostate, so this is the prostatic part. This is the urogenital diaphragm. So this is the membranous part, and this is the spongy part as well. Okay.
And then I looked at the background, it says when the bladder is empty, collapses, so your bladder can never be empty.
What it says?
The bladder collapses when it's empty.
Collapses means squeezes, gets smaller,
Okay.
not fails.
Okay.
Okay? Okay, collapse can also mean failing of the organ. Okay, few more things. Interesting. The clinical terms we use related to the amount of urine. One is anuria. A means what?
No.
No. So anuria is the condition if the volume of urine is almost no urine production. Almost no urine production. That's if the volume of urine production is less than 50 milliliter per day. That's really very low, almost no urine production. Okay. So if someone produces 20 or 10 or 30 or 40, we say that person has anuria, and that is dangerous, kidney failure. Okay. Another is,
So if they have less than 50 milliliters a day, then they're suffering from kidney failure?
yeah, most of the cases. Oliguria. So anuria is almost no production of urine. Oliguria is less amount of production of urine. So less urine production, that is oliguria. So if someone has 300 to 500 milliliter per day,
Would that be like just less than normal?
much less than normal. So if the production of urine is low than normal, that is the oliguria. So when we say oliguria, if the volume of urine is below 500, okay, some people say 300, some say 500. So if it is below 3 to 500, that's the oliguria. Now if it's going really below 50, then what we will say? If it is 100, 200, oliguria. Okay. Some people say 300 is also oliguria. Okay. Some clinician. Okay. So those two. Another is hematuria. What is that? Blood. If you see the red blood cells, the presence of red blood cells in the urine, that is called hematuria. Okay. So red blood cells are erythrocytes in urine. Anything else? Polyuria. Poly means what?
Too much.
Too much. Excessive production of urine or frequent urination. Both are termed as polyuria. Okay? If the frequency increases or the production volume increases, that's
How many
polyuria.
milliliters would that
I see.
What's normal?
be? Yeah.
Normal is our body produces 2 to 3 liters of urine a day. So if it's above that, that's polyuria. If the volume increases more than 3 liters. Okay.
It's
Another.
not how many times that a person urinates.
Also, both.
It's how much they urinate at one time.
Actually, in both cases we say polyuria. If the frequency, that's why I said that frequency as well as the volume. Okay, both. It's the common term. Pyuria. Have you heard this? Pyuria. Okay. Yes. Pus cells in urine. If the urine has pus cells or pus, if it's pus in urine.
What's that called, polyuria?
Pyuria, yes. So if someone has infection, right, there is a chance that you'll see pus in the urine. That's fine. So remember this.
Are these all visible to the human eye? Is hematuria visible to the human eye?
No, you have to look under the microscope. Of course, if a lot of bleeding, then you can tell that blood is getting out. But in most of the cases, you have to see under the microscope, and you know how the red blood cells look like, right? Very easy. If you take a drop of urine and some slide and see under the microscope, you see the red blood cells there. That's
What causes hematuria?
So you said the anuria is less than 50 milliliters a day. So what's like between 50 and 300? Is that, what does that mean? No, but that's between 200 and 500.
yeah, some people, that's the standard, it could be different from country to country. From
So anything more than 50 is oliguria, but less than 500.
Okay. So you will see the standard differs from nation to nation, race to race. You will see when you do the blood test, I don't know here, probably I saw here, that if it's Hispanic, it will be, the race will be like this. It's white, American, this African, this. So standard also varies from. So if 500 is normal for some grades than 300 milligrams. So we not fix the exact volume difference.
This is why this is awkward.
Okay, so that's the urinary system. Urinary system is very interesting. And if you understand whatever we have talked about, it will be very easy for you to really understand the clinical conditions. Because anything abnormality here will cause the clinical condition. That's very important.